Good. So, hello, everybody, wherever you are around the world, and welcome to this news edition of the World Federation of Neuro Rehab webinar series. I'm very honored and pleased to have three very distinguished speakers today. I'm grateful, especially to Professor Gerard Francisco and Jorge Hernandez Franco for setting that up, and also to Ratra Korupulu to join us. Let me also express my thanks to our friends in Romania who help us with the broadcasting of these webinars, always in a very elegant fashion. So I wish all of you a very successful and interesting, exciting webinar. And I give over to Gerard for
Thank you very much, Professor
introduction.
Humbert.
Thanks.
Always a pleasure. By way of introduction, I am Gerard Francisco. I am based in Houston, Texas, and I had the honor of co-chairing the Spasticity and Botulinum Toxins Special Interest Group of the WFNR with my dear friend, Professor Jorge Hernandez Franco from Mexico. I also have the honor of introducing our speaker today, Radha Koropolu, who is an associate professor in physical medicine and rehabilitation in my medical school here in Houston, Texas, the University of Texas Health Science Center, McGovern Medical School. She is also our clinical service chief for spinal cord injury. And in addition to that, she's an attending physician at TIRR, the Institute for Rehabilitation and Research, Memorial Hermann Hospital, where she serves as the chief of the respiratory services. Professor Koropolu has had a distinguished career as a clinician, as an academician. Most notably, she has received NIH grants from the National Institutes of Health grants, which are very competitive in various areas, and it's quite varied, anywhere from topics ranging from mindfulness and spinal cord injury to respiratory care of people with spinal cord injury who are still on ventilators, and very recently on non-invasive vagus nerve stimulation to facilitate upper limb motor recovery in those with incomplete spinal cord injuries. She is one of the top researchers in the United States. She is ranked among the top 75 in the USA in terms of NIH funding for 2024. So without further ado, I would like to introduce my dear colleague, Professor Radha Koropolu.
Thank you, Dr. Francisco. And thank you for this opportunity. Let's see, I don't have my slides sharing, right? I think slide sharing was stopped, so do I have to restart it? Yeah. Okay, here you go. Is it in the presenter mode?
Not yet.
Okay, how about now? Okay.
Yep. Yeah.
Yeah. So thank you so much. So, caring for people with spinal cord injury is my passion. And one of my clinical interests is the managing spasticity. I have been doing this now from almost over a decade and learned so much during this process. And I'm excited to share my experiences with you. How SCI, its spasticity is a little bit different than what you see in the stroke and the brain injury. I don't have any disclosures. So main objectives is to understand the physiological basis of spasticity in SCI and identify the unique patterns and triggers of spasticity in SCI. And we'll go over some of the cases to discuss, the nuances of the presentations and complexity of the management. And how do we manage and the strategies to tailor to these unique presentations? How do we go about it? So prevalence of spasticity ranges from 65 to 78% after SCI, and approximately almost 35 to 49% have problematic spasticity, that affects the function and quality of life. Now, how is it different? Unlike, I think the stroke and brain injury, the factors that affect the presentation and severity in SCI depends on level of injury, whether depending on where you have like a C5 or C6 or C7, completeness of injury. Is it a complete injury or incomplete injury? Do they have any sparing below the level of injury or they don't have any sparing? Time since injury. I have seen the patterns are different during acute stages and the chronic stages, depending on what they have been doing all this time. For example, patients with paraplegia who spend a lot of time in the chair, down the road, they end up developing more hip and knee flexor spasticity because of peripheral changes in the muscle tendon sensitivity. Presence of complications, certain complications in SCI actually make spasticity more pronounced, and I've seen it like absolutely, like especially the pressure ulcers and infections and HO, heterotopic ossification, the bony growth around the joint. And the highest incidence is actually in incomplete tetraplegia. I know you would think it's complete, but no, it's incomplete tetraplegia is the one which highest presentation, especially where people have um, on the basis of Asia grading B and C, where have some sensory sparing and some motor sparing. So that's kind of it's a very different challenges, very different. It's not like we can expect the same pattern. Each person could be very different. So we have to do a very thorough evaluation for that patient so that we understand how can we help them the best. And we'll discuss some of the cases. And pathophysiology, I don't have to tell this audience about central mechanisms, loss of inhibitory input from supraspinal centers. But peripheral mechanisms play a lot of role in chronic SCI because of changes, muscle tendon shortening, changes in the tendon, Golgi tendon sensitivity and joint properties. Other things that we have to specifically keep in mind in spinal cord injury, at the level of injury, people can also have a lower motor neuron injury. And that can be very tricky presentation because you will see some, hypotonia and some hypertonia at the level of injury. And then the other unique presentation of spinal cord injury is central cord syndrome. In some of the cervical lesions, patients have more spasticity in upper extremity and less in lower extremity. So they have spasticity everywhere, but in upper extremity, they have so much more than the lower extremity. So even if they have ITB pump and if you try to increase the dose to control upper extremity, you will become very loose and weaker in the lower extremity. So different. And then sometimes the lower level of injury also, you can have a mixed upper and lower motor neuron injuries. Especially we know the spinal cord itself ends at L2, but there is also, cauda equina around that area. So people can also have a mixed injuries. So basically, we really have to very thoroughly evaluate, these patients to understand what's going on. There were a couple of times actually in my clinic, patients showed up with they were referred to me for spasticity, but on further examination, I found actually they are lower motor neuron injuries and they're complaining of neuropathic pain as spasms or tightness, but on the exam, they were very flaccid and the workup revealed that they have something else is going on, which is related to LMN. So always tell my trainees that examine the patients. Now, what are the, while the patterns may vary, but let's see what are the common spasticity patterns in SCI. Especially cervical levels, with a cervical level injury, shoulder adductors and internal rotators. I think that's common in other too. And depending on where the level of injury, it can be elbow flexors or elbow extensors, but typically elbow flexors, wrist flexors, and pronator. But they can involve all the other muscle groups too. These are most common, but I have elbow extensors I have to inject. There are times I have to inject elbow extensors, all just like any other thing. And lower extremity, most commonly involved muscles are hip adductors, ankle plantar flexors, and hip flexors actually. And this is based on some of the research I have done in people with SCI for spasticity. Now, as I said, there are some certain triggers for spasticity that can make a baseline spasticity really worse in people. And in people with spinal cord injury, urinary tract infection can significantly make the spasms worse. So always when somebody presents to your clinic, obviously probably they're suffering from chronic spasticity, but if we are doing the consults, I always check to see that, hey, all of a sudden, why they're having, do they have a UTI? Let's treat that first, bladder distension can make it worse. Constipation can make it worse. And sometimes all of these things together can work and make it worse. Pressure ulcers. My God, I have seen ischial pressure injuries makes the lower extremity spasms like so bad. And the moment the wounds heal and they have a flap surgery, as soon as the wound is closed with a flap, once and you see a dramatic change in drop in spasticity. And especially, some of my surgeons really want zero spasms before going to the flap. So sometimes I increase their baclofen ITB dose very high. And the moment they have surgery, spasticity has now decreased so much that I have to rapidly bring the ITB dose low. So, and if they have any stress fractures, and heterotopic ossification or DVT, anything can make really spasticity worse. External triggers in people with spinal cord injury, they have autonomic dysfunction, especially cervical level. So they cannot tolerate extreme cold or extreme hot environment because they lose the ability to regulate their temperature. So that can also make their spasticity worse, especially in the summer. If they're outside for a very long time, their body gets heated up. They don't have that autonomic control to regulate their body temperature. Positioning, incorrect seating or prolonged immobility, any sensory stimuli. And actually, I have seen, I don't know how much it applies to other diagnoses, but stress and anxiety, my gosh, anxiety I've seen, especially some of cervical injury patients, when they have when they have some breathing issues, that can also trigger the anxiety, and it also exacerbates their pain and spasticity. So, and the reason it's important for us to know all those things, because just treating spasticity, like, just the symptom is not enough. We have to look the patient as a whole and see what else is going on so that we can make a comprehensive management plan for them and address everything to, optimize the spasticity management for the patient. Now we're going to go over some unique cases and some complex presentations, and we'll see how do we tackle that. So spastic finger flexors and tenodesis. So if we use a lot in the SCI world, tenodesis. So in spinal cord injury, as long as patients have wrist extension, even if they don't have active finger flexion, when you extend the wrist, the fingers come together. When you flex it, the fingers will open up the wrist. So we call it tenodesis, and we use it for actually to perform the activities of daily living. They can grab something with the wrist extension, and then if they need to let go, they just flex it. So if they don't have active motion, tenodesis can be very useful functionally to people. And if they have some finger flexor spasticity, that's amazing, because, that can help them to have even stronger grip. But the only thing we have to make sure that when they flex the wrist, they can open up the fingers. So finger flexor spasticity is very useful in SCI population because of their functional advantage. So this happened actually when I just started as attending my year one of my spasticity practice, So I had a 23 years old female with C6, means she has the wrist extension spade and elbow flexor, and she doesn't have anything other than elbow flexion and the wrist extension movement. A means a complete injury. She came to clinic that she doesn't like how her fingers look, finger flexor spasticity. She was young. She wanted to make sure that she has extended fingers and hands which look normal. On exam, she had finger flexors MAS score 2 to 3. One hand 2 and some fingers 3, and she didn't like how it looked. And she said maybe she has some difficulty opening, letting the grip open the grip. So after evaluation, I did mention to her that possibility of weakness and difficulty, but I also, I think, underappreciated how much it was needed at that time. So I discussed briefly, we decided to go for it. I mean, taking away spasticity is easy. It's always the managing that fine line. So we injected both FTS and FTP with great results. She came with the hand extended, amazing, but functionally declined because she was using this motion to propel her chair. She could grip, she was using this hand finger flexor spasticity. Now she had to do this with the shoulder a lot. So she was hurting with the shoulder. She was using this finger flexor spasticity to open the doorknob, to open the jar. Now she couldn't do anything because she's now extended. She could carry a grocery bag. She cannot carry right now, and she lost the tenodesis, so she couldn't do a lot of stuff. So, so do we not treat at all finger flexor spasticity? No, we treat it, but we have to gradually and carefully evaluate. For like example, in one case, she also had active strength though. this patient didn't have any active finger flexion. I have one case where patient had active finger flexion, but she couldn't let go, because of the finger flexor spasticity. So we started the low dose and we still, did it. And she was eventually had enough ability to open it up. So it's always about the balance. But if they don't have any active finger flexor strength, and it's not like, like a fist or something, we have to be very careful treating finger flexor spasticity in people with SCI because it's very functional, and especially, the tenodesis. Just an example, just was trying to show that when wrist extends, the fingers come together because the tendon shortening. And when the wrist flexes, they can open the fingers can get extended. All right. And then there's another unique case, which you can only see in SCI. You won't see it in the other population. So I had a 45 years old female with C5 AISA. C5 means only she has elbow flexor. She didn't have any strength in elbow extensor or anywhere else. The only thing she has is the active, she can volitionally trigger is the elbow flexion. She's just 2 months post SCI. So I was consulted because her elbow flexor, she always keeps her elbows flexed. So they were worried about her developing contractures. And so I go to examine her. I see that her elbow flexors are 4x5. And she has very flaccid elbow extensors. Actually, probably she had some lower motor neuron injury at that level. She had no spasticity in elbow extensors, and they were actually flaccid. But at the same time on the exam, I didn't notice any elbow flexor spasticity either. So basically, because she didn't have anything to oppose, she was just because of the unopposed activity of agonist, she was always, that's the only thing she could activate. So her elbows are just going into elbow flexion because there was nothing to stop her or extend her elbow. So what do we do in this case? It's a very tricky because she's at risk of, tendon shortening. At the same time, that's the only thing she has, it is a tricky case, I have seen many of some of these patients, if we don't do anything, they come back with significant elbow flexion contractures. So even, so what do we do for these patients? These patients really benefit. Of course, we have to give her some more time for recovery. Actually, my orthopedic hand surgeon says we give some time, but not too late where the tendon becomes short. So at least 6 months to see if there is any recovery. In the meantime, it's really important that we do some kind of splinting at the night to make sure elbows are not flexed and tendon is not shortening. So we usually send them with the splints where they can be in the elbow in extension at night for passive stretching. And if there is no improvement, there is no hope for any elbow extensor recovery, then we recommend them for elbow tendon biceps to triceps transfer. They have to have at least a strength of 4x5 in order to go through that procedure, because when they do that, they lose at least one level. So from the 4x5, they will become 3x5. But they gain actually elbow extension, at least 2x5. I mean, functionally, it's just, life-changing for them. So there is no, what is the use of C5 with a level of 4 if you can't use it for functionally at all? But this procedure can make a significant difference for that patient. Now, let's say if I would have started injecting her with just Botox just to prevent spasticity and not do anything, I'm making her elbow flexors weaker. It doesn't matter how much you make it weaker, she doesn't have any triceps. Her elbow is going to go into flexion, period. And not only that, by repeated injections, probably I'm making it weaker, So the best scenario, I know not everybody has access to such unique orthopedic hand surgeons, but it never hurts to talk. And you can do nerve transfers too in such cases so that they regain some elbow extension to balance the strength between the agonist and antagonist. I think we already talked about, and it's just gaining that strength in the triceps makes a huge difference. People can reach actually to do the activities, and as long as they can actually lock the elbow in extension during the transfers in SCI, they can even be independent with the transfers. So it's a game changer. If you have any access to such orthopedic hand surgeons, please consider that. It can make a big, huge difference. Right. Now, let's talk about case 3, central cord syndrome. I think I briefly talked about it earlier. I have a 65 years old male with the central cord syndrome and severe spasticity. And, in central cord syndrome, people have significant spasticity in upper extremity. So more deficits in upper extremity and less deficits in lower extremity, basically. And then now, but people with in general cervical injuries, you have bilateral upper and lower extremity to deal with, right? So it's not easy to manage because you're trying to manage 4 extremities. And many times my insurance companies will not even agree to give me more than 400. And I have to fight them like, hey, this is based on the stroke study on in just 1 extremity. And I'm dealing with the 4 extremities. And you'll be surprised often actually I'm successful in convincing them that, I need more Botox to manage these patients. But still, 600 units of Botox to manage bilateral upper and lower extremity is not enough. And the other thing I find challenging in people with spinal cord injury, in general, they're quite resistant to pump. Here, patients are making decisions for themselves. They already had a spine surgery. Some of these people require a suprapubic tube, some other procedures, colostomy, and they don't want one more, surgery, and some of these patients actually had spinal cord injury because back surgery went wrong. So some of my patients are quite resistant, and then I have to just, what do we have? Only Botox? No, we can't take care of everything, especially when the multiple large muscle groups. So we really have to use all the tools in our box, And then when I'm talking about management, it's assumed that you're doing stretching, strengthening, splinting, all the other multimodality therapies. And we are talking in addition, what should we do? That's assumed we do all of that. So what did I do for him? To manage the lower extremity spasticity, we did the ITP pump, which controlled the ITP, optimally. But, in these patients, in my experience, if you try to increase the dose, they actually become very weak in legs. And usually they have a significant strength in the legs. They're more weaker in the upper body. So you can't go. And can you do the catheter higher? So if you do catheter higher, they lose the spasticity in the trunk. And these are the people actually can walk because they have a significant strength in the, legs. So if you lose the trunk spasticity and the tone, it affects their posture, ability to stand and, talk. So I don't do the catheter. In my experience, it didn't work. I tried in many patients, So I only do thoracic or lumbar, depending on, what's the pattern. Now, how do I manage upper extremities? Uh, I do both neurolysis with the chemical neurolysis with phenol and botulinum toxin injections. We'll talk about some of these procedures later. So for larger muscle groups, I prefer phenol like pectoralis major or latissimus dorsi. It works very well, for them. And then I leave the, for smaller muscle groups in the forearm, wrist flexors and all of that, I do the Botox. And then, I'm able to optimally manage these patients because if I don't take care of that shoulder muscles, very quickly their shoulders gets, frozen. You see it in, other diagnoses too. And that limits their ability to progress in therapy. And so we have to be very aggressive, especially with the shoulder adductors. So I'm able to manage them successfully using with every tool in my box, especially with these people with the cervical spinal cord injury and central cord syndrome, because they have so much spasticity, especially central cord syndrome. For some reason, you treat them, they come back with even more and more, and because they're also recovering, it's evolving for them. They're very incomplete injuries. So they continue to evolve for certain years, actually. So it's very hard to manage these cases. So I bring them more often and monitor them more closely so that they don't end up getting any contractures. Now, I think, so chronic SCI and paraplegia, some of these patients who are paraplegic, they may not have any significant spasticity early on. So I have a case here who is 4 years old male who was injured at age 25, and he has a T2 level injury. So he's basically paraplegic and kind of incomplete sensory. He works full time. So he sits in his manual chair more than 12 hours per day. And he has a history of ischial pressure injury. So what they do when people have history of ischial pressure injury, and also he's a higher level, right? He's a T2 level, so he doesn't have much trunk stability. So our DME people will add more dump in the chair. So his chair angle will be more like a closed, so that he's like literally even though he doesn't have the trunk stability, he can be more stable in the chair, but it results in excessive hip flexion. So in general, he's sitting in the chair for a very long time, and his chair has so much dump, so much angle, so that he's actually sitting with an excessive hip flexion. So these people are very high risk of developing hip flexion contractures and knee flexion contractures. Now he has spasticity, and also there is a component of contractures as well. So, I've seen so many such cases. So now I'm very proactive as soon as I started seeing early on in my practice these patients. So all the paraplegic patients, I make sure they get a standing frame, so they can take a break from every 3 to 4 hours from the chair and actually stretch their hip and knee flexors. Or I tell them if they don't have a standing frame, go to the bed and just passively stretch it, their hip and knee flexors, because if they sit straight for 12 hours, they are going to get it. And also, if their ischial pressure injury is healed, look at their chair. I always look at the patient's chair. So, because a lot of times some of the patterns can be also how you're sitting. So his ischial pressure injury is healed long time ago, but he kept getting the same chair every 5 years with that excessive dump. So I told him, no, you don't need this dump anymore, because you don't have those pressure injuries. Maybe we can get the dump off a little bit and see, or maybe it's a time for you to go to a power chair where you don't have to worry about trunk stability. Otherwise, your hip flexion contractures continue to get worse. So, but some of these cases, if you catch them early enough, if you do, either pump, or if they're resistant to pump, just doing the Botox, I was able to manage many people, 600, both hip flexors and knee flexors. I do 150, 150 on, each muscle group. I was able to take care of their spasticity. I have many patients actually down the road, they did not even require further. So pump, if they're agreeable, depending on how bad it is, what else is going on. If not, even just Botox itself in hip and knee flexors, repeated injection can also help. But also, and the other thing, before standing, if they're chronic SCI, we have to make sure to get a DEXA scan. They could have a lot of osteoporosis, and, they may not be a good candidate. So don't forget about them. But it's very important that people with a paraplegia, you have some kind of stretching program and emphasize that they cannot sit long for 10 to 12 hours. All right. And in some cases, when people already have some kind of neurological injury, something new happens, often I feel like we don't take into consideration as we do same level, we don't give them attention as if we would have done to somebody who does not have any neurological deficits pre-existing, because it's so murky. There is so much going on in these patients. It's so hard to tease out, so that's why continuity of care is very important. If they're managed by, different physicians and there is no continuity of care, it's hard to figure out some of these nuances. So I had a 55-year-old male with history of cervical myelopathy who required cervical laminectomy in 2022. And actually, he significantly recovered. And he was walking without an assistive device for last 2 years. So he was doing amazing even though he had a cervical spinal cord injury. Suddenly, he started experiencing severe abdominal spasms. He didn't report any new weakness in bilateral lower extremity, no new sensory changes, no bowel and bladder changes or anything. So it's hard. So initially, even, I was thinking maybe he's really constipated. And actually, he was constipated. So we were managing, but these spasms would not respond to anything. So I'm like, okay, there's something else is going on. Let's figure it out. So ordered an MRI. So sometimes you're looking for C rings, but it's not that's where not he had the injury. His injury was a cervical level. C rings happens where, you have an injury. So actually, he had a new thoracic myelopathy. So I referred to surgeon for surgical decompression, and his abdominal spasms went away. I had quite a bit of patients where, especially, it's not traumatic if it is a degenerative disease like a cervical spondylosis. And actually, I wrote a book chapter along with one of my colleague, Dr. Matt Davis. If you have some DGD happening in the neck or happening in the lumbar level, there's a 50% chance it's happening in the other side if you have not examined. So it's very important for these patients, if they had a history of spondylosis and something new is happening, examine the lumbar level too, or the other sites too, because maybe you address that. You thought that's the only problem, but we didn't examine the, lumbar level, or people with the lumbar level, decompression, the cervical level. And over the period, over the last decade, I had seen quite a bit of cases, and often, unfortunately, these diagnoses gets delayed because we assume that, especially if it's coming from the previous neck injury, we assume some of these symptoms are chronic, happening from his chronic neck injury. It's easy if something happening in upper extremities and he had a lumbar stenosis, we immediately jump to it. But with the cervical injuries, sometimes. So always, if something new is happening, we need to do a thorough exam and think about all other possibilities so that we can save them from deteriorating and jump and do something about it sooner before it's too late. Let's say how we're going to talk about some of the management strategies tailored to unique presentations. So I'm not going to preach you about oral medications, but just for the sake of completion, quickly go. In general, in people with SCI, baclofen is very well tolerated. Only thing we have to monitor the dose in people with renal impairment. We are quite aggressive with the baclofen. We, at least in our institution, even the FDA approved is 80 milligram, we go up to 30 milligram every 6 hours, 120, and quite well tolerated in general. And I have certain groups of patients, they have a severe chronic spasticity. And if they have a very significant anxiety and insomnia too, especially when they have a lot of pectoral spasms, it really affects their ability to breathe as well. So while I'm waiting for them to, do other things like injections and all that, they're so miserable actually sometimes. I use a small amount of clonazepam. It works very well for them. It helps with their anxiety. It takes care of their chronic spasticity. Usually people with SCI, they don't have any brain injury or cognitive deficits unless, there could be few cases where they have a concomitant. They tolerate it fine. And I make it very clear to them that I'm prescribing only until you get to the injections or whatever is the pump. But once you get that, I'm not going to prescribe them. And I make it very clear. They're very grateful usually. And, and once they get the definitive treatments, I'm able to stop it. Tizanidine, I used to be very excited when I first started as an attending, but now in my experience, it works, but it causes a lot of weakness. My patients do not tolerate very well. And besides, ciprofloxacin is a very commonly prescribed antibiotic in the community for UTIs. People with spinal cord injury are very prone to UTIs. It happens quite frequently in the community. And often also it's actually misdiagnosis too. The moment they see anything bacteria in the urine, they'll start treating it without taking consideration into what other factors we have to take into account to manage UTI. But if you take the tizanidine and cipro together, tizanidine levels can increase in the body up to 10 times because of P450 interaction. So that's the other reason I stopped doing it, because I've seen it quite a bit enough, in community, people getting prescribed Cipro while they're on tizanidine. I don't feel comfortable, unless absolutely patient is very educated or something. Dantrolene, you can use as a peripheral agent. I have not seen much success with the dantrolene in my population, but I don't use it as a primary agent, but I use it like an adjuvant treatment option in few cases. Now, just like the other diagnosis, we also, interventions are like botulinum toxin, neurolysis, intrathecal baclofen pump. We use tendon transfers, nerve transfers quite a bit because I think we are fortunate here in the medical center in Houston, which is one of the largest medical center in the world, access to world-class surgeons, and we have excellent collaborations with them. So we use quite a bit of those procedures to help our patients. And then at the end, we know that spasticity requires multimodal approach for optimal outcomes. It's not like just one thing. I tell them that doing medication injections just one part of solving that puzzle. You have to do all these things too, otherwise it won't work. See, even if I inject somebody, but his arm is like that and there is no stretching, it won't be helpful, right? And then I guess just like a stroke world, in the world of stroke and brain injury, in the SCI world also, we always debate early versus late interventions after acute SCI. And I'll share my experience of just treating people with SCI, over a decade. What do I see, Um, there is no clear guidelines, even in the world of SCI, what is the best, and often still clinicians, I have spoken to some of the world-class researchers in SCI, even recently, they say, no, I've seen the moment I have a baclofen pump, they lose the, ability, they lose their movement. But at the same time, I'm a clinician and a researcher. So that gives me an edge to see both. I follow the patient on the long term, right? So I see what happens to them if you treat them and if you don't treat them, you know. So I'm going to discuss two cases and see what happens. So I have a 40 years old male with C4 incomplete injury. Incomplete injuries have a lot of potential to get back to walking, up to, especially somebody with C, up to 70% chances of you getting back to walking. Now, he came to us very late, unfortunately. He was lost somewhere in the community because he didn't have insurance. But by the time he came, and these are the people who have a lot of spasticity, especially during when neuro recovery is happening, I see a lot of spasticity. He came to us with a severe contracture in 6 months. He developed severe contractures, and because of poor positioning, he developed severe pressure injuries. And because he was so contracted and he has so many pressure injuries that people in the nursing home were not even getting him out of the bed to the chair, you know. And we did whatever we could do to help him, but it was definitely too late. And I always used to think when, this patient has a very special place in my heart because, we did a lot for him. Unfortunately, he passed away due to complications of the pressure injury and sepsis. But I always wondered if he would have come to us sooner, probably he would have walked in the community, his outcome would have been different. So 6 months, not even a lot, and actually he told me he developed these contractures within first month of the injury, actually. So now I have another patient, similar type of injury. He's 36 years old, male with a B, actually. He's not even C. He's a B, means he doesn't have any motor sparing, only sensory sparing, so he has a less chances of recovery. So when he was inpatient, he didn't have that much spasticity. So usually people have a traumatic spinal cord injury, they go to acute care, and then they come to our acute rehab hospital, inpatient rehab. And then they are here for 6 to 8 weeks, and then we discharge them home. And I've seen him inpatient. He didn't have much spasticity or anything. And then we sent him with outpatient therapy. Then he comes to my clinic because the therapist, he developed such a severe spasticity in bilateral lower extremities that he couldn't even participate in therapy. So therapist said, first go and get treated your spasticity because there's nothing I can do. So he came and he was in the clinic in my, on the bed in the fetal position or with the knees to the chest. And I couldn't even I couldn't even extend it. And because he was spasming so much for any attempt to move it. So forget about checking even motor strength. So he's only 2 to 3 months post-injury, but I know what's going to happen to him if I leave him like that. He's going to develop contractures and no potential. So what is the fear of not treating spasticity when we know that he's going to develop contractures and he's going to decline functionally? So I took a bold step and I said, we're going to go for ITB trial. And I sat with him, I explained it to him, and we went through the ITB trial. It was in the beginning of my career where I'm myself learning and, weighing the risks and benefits. But I said, no, I'm going to treat him after seeing that patient, the other one. So we did the ITB trial, we put the ITB pump, and usually we bring the people back after 6 weeks. And then after ITB placement, when he came back to us, he had a significant pre-existing motor recovery. Actually, we noticed some of it during the trial, but as soon as we controlled the spasticity, he developed so much motor recovery. And actually, he's walking. Now, ambulatory, the walker, he requires a very small dose, actually. I mean, if we would not have treated his spasticity with intrathecal baclofen pump soon after his injury, I don't think he would have been where he was. His probably outcome would have been like one of the other patients where he ended up developing a lot of contractures. So if you see severe spasticity, and since then, depending on how much they have spasticity, I don't usually hesitate to treat them. And actually, I don't remember I had any negative outcome. For these patients, they do pretty well, especially with the Bs and Cs. They have an immense potential to recover. Okay. Now, there are some challenges with ITB therapy in SCI. Is everybody a candidate for ITB pump? No, as I said in my practice, one of the things I often, have to face, even I had a case yesterday, some of our patients who have a DJD, they have extensive surgeries in thoracic and lumbar level, resulting in fused spine, and we are usually not able to do ITB trial. I tried to convince some of my surgeons to see if we can put the pump in them without the trial because we cannot do the trial at the lumbar level. Unfortunately, it seems like the canal also is very small and they're often very afraid because it requires more extensive surgery. Seems like even tunneling the catheter can be a challenge. So some of these patients are not able to have the pump. Coagulopathy, some of the patients, so we always, before we do the ITV trial, we always do the blood work. And there was, I would say, maybe 4 to 5% of those people, we ended up finding some kind of coagulopathy where INR is too high, or they had a recurrent DVTs and PEs where they need to be on the long-term anticoagulation, and we cannot even afford to be off the anticoagulation even for the surgery for 2 weeks because there's such a high risk of PE. Yes, you can put the IVC filter for them, but you still cannot, they still at higher risk of having clots in upper extremities too. Lack of funding or resources, sometimes if they don't have the insurance or continuity of funding, right, because the refills are very important. So some of those patients are not able to get, the pump. Sometimes they have a significant epidural abscess and osteomyelitis. So there's ongoing infection, or even if the epidural abscess is decompressed, they're on antibiotics. So I have to involve the ID in such cases to see once they're treated, if they're ready to have the pump. So it's it requires a lot of coordination care. And as I said, the patients, I noticed definitely there are good subset of patients who don't want the pump, or I would say 25% don't want period and 25% they want to exhaust everything before they get to the pump. And of course, it's a surgery. So I will always respect while continuously trying to teach them why it is so important for them. And then lack of coordination of care. I don't know how it works in other countries, but we have so many specialists, so it's so hard to coordinate the care. And I'll discuss one such case to you guys, where coordination of care becomes quite challenging, but if you do, it can make a huge difference. So I had a patient who was 61-year-old. He has, end-stage renal disease and he's on dialysis. He had a PE and he's on anticoagulation. He's obese. Now he developed epidural abscess and he became, now he's a paraplegic. He also had a severe spasticity, MAS 3s and 4s in bilateral lower extremity, hip and knee flexors and hip adductors. He was discharged to nursing home. So the primary team did not consider him for an ITB candidate because of obviously all these comorbidities. So sometimes it's a lack of knowledge also. They were afraid, like, I don't know, he's on a hemodialysis, and, is he be okay? He's on anticoagulation. So he returned to my clinic on a stretcher from the nursing home. He stays in bed all day because people don't know how to transfer and position him in the chair. I mean, he's a big guy. He's like a big 6 feet guy, and he's obese. So, and with all this spasticity, it's so hard to even position him. So he remained on the bed for the last couple of months, and staff, as I said, not able to transfer. So I said, okay, let me see what I can do. So I had to first call the nephrologist to see what does he think about actually intrathecal baclofen in the setting of end-stage renal disease. And we discussed a long time. We both did a literature review. So when you take it orally, your blood levels are 10 times higher compared to when you deliver it intrathecally. You require such a smaller dose, right? Because now you don't have to worry about, penetrating through the blood-brain, those membranes, which are not soluble to baclofen. So the dose that you require is so small, then actually it is safer. And not only that, with the people with end-stage renal disease, it's because it's delivered it to the CSF, so it's not like it gets accumulated in the blood or anything because the dose is just so small. So he, after talking and debating a lot, he thought actually for people with end-stage renal disease on dialysis, actually pump is better option than oral medication. So we solved one problem. Now we talked about PE. So it was only one PE and he was already treated. And the PCP, after thoroughly evaluating, and the cardiologist gave us a red signal, they said, okay, we can get him off the anticoagulation and put him on the Lovenox, during that perioperative, so minimize how long he can be off anticoagulation. Then we have to talk to his infectious disease person, because for epidural abscess, he was on quite a bit long-term antibiotics. Then after talking, they said he's past that stage. If anything, he's on suppressive antibiotics. So hopefully he will be, fine based on, because you have to weigh the risk and benefits, right? So, and that changes the risk and benefit depending on how your patient is presenting. this guy, if we don't move him, he's going to die soon of getting more PEs because of immobility, contractures, pressure injury. So it's always your way, this risk and benefits balance changes, right, with the patient scenarios. So finally, after getting all the clearance, which took a while, we put the ITB pump in him. And he did amazing. He came to, it's been now over 3 years, no complications. He's doing amazing. Once his contractures all were able to go, he actually independent at the wheelchair level because he's a paraplegic. He's a very strong upper extremity. But if you would not have taken all these steps and the pain of coordinating his care, probably his outcome would have been different. And this case, actually, I published it. And I remember the day I finished writing, I sent an email to Dr. Francisco. I feel so good. It makes me happy that, we did this. So yeah, thank you. Now I actually did a retrospective study on ITB data in SCI just to get idea what's going on in this patient. How does it look like? Let's see if we have time. I can quickly go over. I looked at 147 adults with SCI who received the ITB therapy. Most of them were, traumatic SCI, 89%, only 11% of non-traumatic required pump. At the time of, they're relatively younger patients because SCI, if the traumatic SCI is a younger population in general, so that's why we have a younger cohort here. The median MA score at the time of referral was, around 3. So in general, unless you have a severe spasticity, it seems like in SCI, we don't get referred. And if you look at the median age, they don't, over looking at the overall cohort, the median age is actually since injury is 2 years. So not many people want to get the ITB early on. But what most important is dosing in general. Non-traumatic people require higher dosing because I think, for example, MS and myelitis, it's more dynamic, right? It's not like once you had a spinal cord injury, you're stable. But traumatic SCI, the median dosing was 300 microgram. It's more stable injury. It's not like it's getting worse or anything. I'm assuming that's the reason probably. But one of the things I've found that, but the pump site infections were quite common in people with SCI, 13%. In general, people with SCI have their immune system is also affected. And in general, they're very high risk of infections. I'm wondering if that's also the reason they have a higher, pump infection. I have noticed the catheter malfunctions is quite a bit high, actually more recently with the newer catheters. I don't know what's your experience. I've definitely noticed more catheters clogging, obstruction, and recently we talked to some of our neurosurgeons and we were able to minimize some of it. So it could be something surgeon related, but definitely the newer catheter. Newer means it's not very new. I know Ascendua catheter is now there for quite a while, but definitely I think compared to previous catheter, I think was more prone to fracture. And I think this catheter is more prone to forming a granulation tissue, especially where it gets connected to the pump. We have to be more careful, I think, especially when we are sending them for pump replacement at 7 years. I have noticed actually that's the time when they don't replace the catheter. So they're basically connecting the catheter, which was already used, right? So that's when I'm seeing they have a more obstruction in those cases. These are the two common malfunctions. Some of the patients we say pumps gets flipped. It's not very common now. There were some of the older patients like maybe a decade ago, but site infection and catheter malfunction were the most two common problems. I'm going to skip the conclusions. Just wanted to quickly go over phenol neurolysis safety in people with spinal cord injury. It's very safe. I know it depends on how you do it. And the reason I did this study, because so many people often express that, oh my God, we're going to have them, they lose sensation, they become weaker. It depends on how you're doing it. I tell all my trainees, you have to know anatomy, motor branches, mixed nerves. Patient is complete or incomplete. Does he have a sensation? So most of these patients were injected by me, in this cohort. 6% phenol or 40% ethyl alcohol you can use, but in this, usually I use 6% phenol, and 3% phenol will cause demyelination, and the effects won't last very long. You need at least 5 to 6% for axonal degeneration. The good thing about phenol is it's an immediate anesthetic effect. So when you are doing the neurolysis, you can see immediately and you can titrate it as you go. So there is no consensus on the highest dose, but in general literature, they recommend up to 1.2 grams is totally fine, which is 20 ml of 6% phenol. But in general, if you're really skilled, you don't even need that much. I barely use more than 10. It's very rare even to use the 10. It's, unless it's a multiple nerves. As I said, the possible adverse reactions, pain, bruising, dysesthesias. Dysesthesias happens only if you're doing a mixed sensory nerve and the patient has intact sensation. But if you're only doing the motor branches, you don't develop that complications. And if you are actually, so what do you do if you have a dysesthesia? You go back and complete the block, right? But then patient will lose the sensation in that distribution. So you have to be very careful. You can sometimes have a swelling of limb, incomplete block can cause CRPS type 2, but all these risk is less than 2% in my cohort. Very rare, nothing long lasting, So it's a quite safe actually, and it's an amazing tool to incorporate in the spasticity analysis. Unfortunately, let's see, yeah. So just to show that phenol, this patient was inpatient, and with the help of phenol and, stretching and bracing, how elbow flexors who are attached to the chest, now you can see they're completely extended. And I think it's the results that we were talking about. As I said, the median dose that we use is very low, around 4 ml from all the procedures that we have done it. Most common is obturator nerve and pectoral nerve. I definitely keep it for more larger muscle groups, but if sometime needed, I do it for the smaller muscle groups too. And also, because now we use the ultrasound guidance, I feel personally it's much more safer and we can use a smaller dose, because with e-stim, you don't know how far you are from nerve, what you're doing. I think that could be the reason in the past people were using higher doses and more adverse effects. With ultrasound, the doses that we require is so low, and also probably minimizes some of these side effects too. But definitely we need more larger studies to assess, prospective studies to assess safety, efficacy, and everything. This is one of my patients who came totally flexed up and down, how we were able to get him to the standing from totally flexed position with hip and knee flexion, MAS3 to all the contractures. And he required everything, ITB pump, Botox, stretching, phenol, splinting, multimodal therapy. So we can do it. We can help our patients. All right, so spasticity in SCI is a multifaceted challenge and requires comprehensive management. We have to, early management is very critical to prevent complications, and tailored interventions based on individual needs yields the best outcomes. We have to see each person come up with it. We can't have the one recipe for everybody, especially if the presentations are so unique. So thank you. I'm going to stop here for questions, and if you need references, I have it here.
Thank you, Dr. Koropoulou, for this very interesting presentation and for sharing with us your experience based on these cases. So I think we open now for questions. If you want to pose your questions. Well, we have the questions. I have one question, Dr. Koropoulou. Sometimes we have to treat patients with MS, multiple sclerosis, and most of the symptoms that they present resemble spinal cord injury patients. Do you do the same approach with them? Do you transport it or do the same treatments with them, even though they have multiple sclerosis?
So in my experience, with multiple sclerosis patients, they have more extensive spasticity patterns. And actually, they use that spasticity to ambulate. And they're more sensitive to spasticity interventions compared to our spinal cord injury. They require even more very slow, because even if you take away their spasticity more, because they're more ambulatory compared to and they want to keep their ability to ambulate until the end, even when it's so severe, the spasticity. So I have some cases where even you do a little bit more, they can't ambulate because they were using the knee extensor spasticity. So I have to be usually more careful with them, actually go very slow, more slowly compared to the SCI patients, because often they use spasticity for a lot of their activities and their extensor patterns. But with a careful and slow process, you can get them, make them more independent.
Thank you. So we have one question from Aziz. It says, how closely do you work with occupational therapists in the cases you mentioned?
So inpatient setting, it's a teamwork. The moment they consult me, because you are only, even same with outpatient setting, we have a very good system here. We all use the same electronic medical records. We can all chat. So because you are evaluating them in just one snapshot, right? They're just coming to clinic once, and spasticity can change so much during transfers. So one, we have actually dedicated physical therapist in the clinic who helps us with sometimes some of these assessments. And two, we communicate. Actually, they send us the notes actually from the outpatient therapy that, hey, Dr. K, this is what we are seeing, please evaluate, and this is what my recommendation. Same thing in inpatient therapy. Actually, I go to therapy gym when they're getting the therapy, when I get consulted to see what is happening when they're doing therapy and get the therapist input. I think that makes the spasticity managed intervention, what we can do to patients, much more. We work very closely with occupational therapist and a physical therapist.
Okay, I have one more question from Mandy. With brown sequard with severe spasticity and spasms, I don't know, it's probably not complete question. He's mobilizing with assist of one and the stick, but very limited. What modality would you recommend? The question is about brown sequard and your approach, I guess. So I don't know if you could
Can
talk
you do
about your
repeating that question?
experience with brown sequard patient. Yes.
So they're asking my experience with the brown sequence patients.
Yes, I guess it's better to ask you that way because the question is not so very clear.
I'm wondering they are talking about central cord syndrome because brown sequence, it's a hemiparesis on one side. It's very, very rare that you see the brown sequence syndrome. So central cord syndrome, I mean, if you are asking about central cord syndrome, it is challenging. But as I said, physicians are just one part of the spasticity management, working with your team, managing spasticity as you're, helping them decrease their spasticity, improving their function. You were working with this. So always prescribe therapy as well after my injections, because if you just inject, they're not going to improve automatically, right? They also need a therapy team to work on once your spasticity got better, working on transfers. We work with the family members also, involve them in the transfers too, right? Because if they need assistance. So it's a comprehensive management. It's just not physician. It's a PT, OT, your team. So make your team, so that you can help your patients the best.
Okay. So we don't have more questions. Gerard, do you have one question, Volker?
Yeah, thank you for a very good talk. I think it's very important, and you mentioned that spasticity is not just bad. It may sometimes be even good. And of course, the benefits and the risk have to be outweighed in spasticity training and treatment. I think that's very important to underline this in order to avoid over-therapeutic endeavors, which may at the end be harmful. One question is there specific pain control management in spasticity?
So the pain control, all my patients have simultaneous neuropathic pain too. So sometimes it's partially from the spasticity, but in general, these are the incomplete injuries. They have a neuropathic pain a lot. These are the patients who coexisting. We use, usually pregabalin and gabapentin is a choice of drug. And I know I just saw an email that pregabalin can cause more congestive heart failure. So we have to be more careful. But usually those are the medications we use more commonly. But I have had actually quite a bit of patients. The moment we have them on intrathecal baclofen pump, their pain significantly decreased actually.
Yeah.
And actually we are writing a case report with my resident on that, like how intrathecal baclofen pump can decrease the severity of the pain in SCI patients.
Okay, do you ever use morphine in SCI patients?
Morphine, are you talking about morphine? No, only during acute phase. We usually don't use it in the chronic phase because they already have so much constipation, neurogenic bowel, and any opioid use just makes it so worse actually. And it doesn't help with their neuropathic pain much either. So we use more anti-epileptic agents to help with their pain. I mean, in some cases we do use opioids, but definitely not morphine.
Okay, good. Thank you.
Thank you.
So we have time for one more question. Two questions actually from Jamie's story. The first one is for the C4-5 clients, do you find any benefit in spring-loaded elbow braces to facilitate the extension?
Yes,
that's the first question from Jamie's story.
Absolutely, yes. We have the patients with different kinds of braces. We have a bracing specialist, right? Especially people if they don't have the elbow extension, if they can flex and they just let go. If they don't actively keep them flexed, they can extend actually automatically. They can go more controlled extension. So we use that while we are waiting for some of, the other things. So depending on insurance, if, not every insurance will cover those kind of fancy spring-loaded braces, but absolutely bracing is a big part and altogether a different talk. To minimize the side effects of spasticity, at the same time to use the spasticity for functional advantage. We work very closely with the orthotics. Actually, we invite the people, orthotic consultants to inpatient side, and the same thing in outpatient when we are making. So we don't just send them to the orthotic department or to them. We actually invite them while the PT and OT is evaluating them, so that we make the perfect brace recommendation for these patients.
And Jamie Story also asked about spinal cord stimulation, TSCS. If you have explored management spasticity with this approach, because what tells us that we have a device on trial claiming to help with spasticity, but the evidence is not the best at present. So your comments about that.
Yeah. So
Stimulation.
spinal cord stimulation, they're studying more for motor recovery, and actually personally went to attend. We have a colleague in our, in medical center who does the spinal cord stimulation. Actually, what happens when they're stimulating they're increasing the stimulation to muscles to fire, their spasticity is actually severe, really bad. And actually that's helping them to actually stand. Actually, I've seen they're spasming like crazy. So it might help with the motor recovery. I think they're still trying to figure out all the stimulation parameters and everything, but I don't think, at least from the literature, I know I just came back from a spinal cord injury conference where we know yet that spinal cord stimulation can help spasticity. I know they're trying to use that tonic contractions to help with the hypotension and ability to stand and, increase them to cause the neuroplasticity. But I haven't seen actually it makes it worse, actually, spasticity, when the spinal cord stimulator is on.
Okay, so Gerard, I think we don't have much more time for questions, so I'll hand the mic to you to wrap up and close.
Thank you.
Great.
So I can go, Dr. Francisco?
Yes, you can go. Thank you so very much.
Thank you. Thank you. Appreciate it. Thank you.
Thank you.
Thank you, everyone, for participating in this webinar.
And thank you for the opportunity. Thank you.
Yeah, good. And our technical support team, thank you as well.
Thank you.
Bye-bye.
Bye-bye.